Hi all, and welcome to How to Avoid the Impact of Looming NHI. My name is Jules Ellen Rowland, and I am from Integrated Health Association. So before we get into the lecture, please read the disclaimer and take note that all the information given here is for informational purposes only. Please don't make any changes in your lifestyle or your diet without discussing it with a professional medical practitioner or discussing it with your personal doctor. So just a little bit about me. I initially qualified as a podiatrist. I then went on to get a degree in psychology and communication. I studied kinesiology healing modalities. I am certified in exercise science and sports restoration therapy, health and nutrition from the United Kingdom, functional medicine from the United States, and my sub-studies include detoxification, hormones and sexual health, insulin and insulin resistance, stroke, and genetics. So, of course, the reason you're even looking at this is because the rather alarming NHI bill has been passed. And there are a lot of challenges that are associated with it. So I want to go through an overview of the NHI and what we as individuals can do to ensure that we don't get sucked into that vortex of NHI in terms of our own health. So the challenges that have arisen with regard to this are who is going to fund this? How is it going to be effectively implemented? Now, the suggestion is that it's going to take anything from 5 to 10 years to implement. But of course, it could be within 2 years. There are some advantages to that in that there are changes that we can make to our own health within that time frame to help us avoid the impact. When is it going to be fully operational? Of course, that is a growing concern. Now, these are very important. What will be the standard of practitioner and support care in South Africa if NHI is implemented? Now, we all know that there has been a brain drain in terms of medical practitioners, and I suspect that there will be another brain drain of medical practitioners moving out of South Africa as NHI is implemented. Now, how does that affect us? It just means it reduces our pool of doctors that we can approach if we have health issues. And that raises the question of, if I do have health issues, am I going to be treated timeously if I need it? Am I going to have to pay extra for good versus just adequate care? Am I going to be put at the end of a long queue where non-emergency routines I might be treated a year from now? These are all very legitimate questions that are arising as NHI is under discussion. So, of course, the impact of NHI is very uncertain. Are we going to be able to get prompt treatment? Will it take time to roll out? Have you got time to affect our own changes? And in this, I would say we probably do have time to affect our own changes. But in affecting our own changes, what do we do? What is going to be a change that we can bring into our life that is going to impact whether or not we're going to get sucked into that vortex? Can we minimize or eliminate our need for medical care, either in hospital or out of hospital? The question we also need to ask ourselves is, very often we are under the impression that medical care is going to save us, that medical care is completely safe. And as a result of that, we don't address medical issues ourselves. We don't address health issues ourselves because we believe that if we get sick, we're going to be saved by the present medical health system. Now, never mind about NHI. That's just one problem. The question we also need to ask ourselves that even if NHI didn't exist, how safe is medical treatment? And not just medical treatment in South Africa, but medical treatment all over the world. Now, fortunately, because of the internet and the accessibility of information, we are in a position where we can research what we need to do to affect our own health so that we can take control and we can empower ourselves. Now, the present healthcare perceptions, as I said, we believe that when we get sick, we need medical professionals to save us. We need pharmaceuticals because they are going to make the difference. And we don't really look at, are there any other effective options that we can do that are going to make sure that we don't need to fall back on other people to take responsibility for our own health. Now, with the COVID pandemic, we had the rude awakening that when we did need medical care was not available to us. The hospitals were closed. We were not able to get into the hospitals unless you were virtually on death's door. Our doctors were available only via Zoom or on any of the platforms. We were really left out in the dark. We didn't know who to turn to or what to do. So it's worth us looking now at any other alternatives. Are they safe and effective? Are they accessible? Can we action them in our own life? And how do they compare with the present medical treatment in terms of safety and efficacy? So I think when we're comparing any action that we are going to take personally versus what is available, we want to get a realistic overview. So let's have a look at the question, is medical treatment as it stands now completely safe? So when we look at what we're giving up, if we are worried about NHI and worried about accessibility to medical treatment, how safe is it anyway? And if we take action in improving our own health and we compare it to the safety of standard medical treatment, how much are we actually giving up? So the term iatrogenic refers to adverse effects caused by correctly prescribed medical treatment, either inside or outside a hospital. So this is not even mistakes that the medical profession might make, or disasters or something like that might happen in a hospital. Iatrogenic refers to correctly prescribed medical treatment. Iatrogenic causes of death are arguably the greatest cause of death even before heart disease and cancer. And much of iatrogenic causes are unreported, mainly because if a side effect is reported, many of the doctors don't refer that on because they fear litigation, and that's understandable. They don't want to put themselves in a position where anybody's going to scrutinize their practice because they worry about being sued. So if you just look at some interesting statistics, obviously these are from the United States of America, but I would say that this is a first world country. We are probably now a third world country. Is it likely to be worse here in South Africa or better here in South Africa? So if you look in the United States, 18 to 25% of people who were recently ill suffered from some kind of medical or drug error. So that's nearly a quarter of people. Only 5.22% of medication errors are actually reported. So if a mistake is made, only a small percentage of these errors are even reported and therefore recorded. So when they look at the numbers of iatrogenic causes, they are underreported. So they're not accurate numbers. In a 300-bed hospital, the number of errors per day was 40, so that's quite a high percentage. 4.7% of hospital admittance was from serious drug reactions from correctly prescribed drugs. So these are doctors or hospitals or practitioners that are prescribing medication according to the accepted code of practice, and yet there are still 4.7 serious drug reactions from those drugs. And the worst reactions are from the SSRIs, so those are selective serotonin reuptake inhibitors, so these are prescribed for depression. The non-steroidal anti-inflammatories, these are prescribed for pain, and the calcium channel blockers, these produce the worst reactions. Now, of the 198 drugs approved between 1976 and 1985, obviously there are more since then, but most of those are still on the market, either in their principal form or in a generic form. 102 had serious post-approved risks. That's more than half. In terms of chemotherapy is the standard treatment for cancer. 3,000 articles were examined on the value of chemotherapy in advanced epithelial cancer. So epithelial cancers would be something like breast cancer or colon cancer or prostate cancer. And this was published in the Clinical in clinical oncology. So it was published in an accepted, approved oncology journal. The overall contribution of curative and adjuvant cytotoxic chemotherapy to a 5-year survival rate in adults was estimated to only be 2.1%. So that is extremely low. So if you're looking at it from the perspective of how much does it help me or how much does it cure me, you're looking at a very low percentage. And then when you marry that up against the side effects, the question to ask is this going to be right for me? And if I do not have access to chemotherapy, am I going to die? What are my chances? X-rays, are they safe? We have X-rays willy-nilly. They're one of the things that it's a diagnostic procedure that is routinely done in hospitals. So let's say, for example, you go for a CT scan. One single dose of radiation in a full body CT scan is 14 to 21 milligrays. And this was shocking, is equivalent to being only 1.5 miles from the blast of an atomic bomb in terms of radiation. It's also equal, so one CT scan is equal to 100 chest X-rays or 100 mammograms. And because medical treatment generally is unreported and has undocumented risks, even in first world countries, if we look in South Africa, where generally, certainly in the government hospitals, things are not efficiently run, can we say, is it likely to be better here in South Africa or is it likely to be worse? I would say it is definitely likely to be worse here in South Africa. If medical treatment is not as safe as we have been led to believe, and NHI might be increasing the poor statistics of safe medical treatment, can we, in our personal capacity, make any changes that are going to give us a blanket improvement in our long-term longevity or reduce our risks of developing diseases? And I think that the best approach to this is for us in our individual capacity to address our risks of developing non-communicable diseases. So of course the communicable diseases would be a virus that we might catch or bacterial infection that we might catch. But the non-communicable diseases come under the following headings. So, for example, any heart and cardiovascular disease is non-communicable. It is a disease that we develop from various triggers and causes, predominantly lifestyle. Cancer is another one. Alzheimer's, Parkinson's, dementia, diabetes, any inflammatory condition. I haven't listed them all, but for example, rheumatoid arthritis, tendinitis, or irritable bowel syndrome. Obesity and belly fat. Obesity and belly fat is not really considered a disease per se, but obesity and belly fat, they predispose us towards developing other non-communicable diseases and depression and mood disorders. So the present treatment, when we go to our medical practitioner or we go into a hospital, at present, when we treat it for the non-communicable diseases, each condition is treated as a separate disease with a separate drug and usually under the auspices of a separate specialist. But is there something that is a condition that we can manage that is in common with all of those non-communicable diseases? So in actual fact, non-communicable diseases all have as a root cause or as a contributing factor insulin resistance. Now, of course, I am oversimplifying this. Insulin resistance is extremely impactful and it is something that we can affect change in our own body. But there are other factors as well. So you may find that you affect a change with insulin resistance and yet you still struggle with the non-communicable disease. And then obviously your contributing factors may be additional to this particular one. So insulin resistance is associated with obesity. It's associated with metabolic syndrome. So for example, high blood pressure as well. If you've been diagnosed with metabolic syndrome, there are certain factors that actually contribute to your diagnosis of metabolic syndrome. They contribute substantially to any risk of cardiovascular disease and as well as cancer. insulin resistance is associated with type 2 diabetes. So what very often happens is that a patient will start with insulin resistance and it will develop into type 2 diabetes. So pre-diabetes and insulin resistance, generally that term is interchangeable. It affects our mood and our motivation, and insulin resistance is strongly associated with Alzheimer's, memory problems, poor concentration, and dementia. So if we can address insulin resistance, you can see that because it has a blanket impact on all of these conditions, addressing insulin resistance will help either manage an already diagnosed condition more effectively, or it will help us to reduce our risks of developing these particular conditions. So how do we go about reducing the risks for all of these particular conditions? Education is very, very important. And fortunately with the internet and our accessibility to the internet, there is always very good information out there. The only problem, of course, is that very often, if one isn't in the health industry or you have another occupation, sometimes the time to educate oneself is not always so easy to get to. Lifestyle modification. Now, there's always lifestyle modification when you are addressing a condition such as insulin resistance. Just thinking, I can take a pill for it, I can take metformin, is really not going to be adequate if you want to make a proper impact in reducing your risks. In reducing the risk, it's going to reduce your need for any medical intervention. And as I mentioned, reducing insulin resistance has a blanket effect on other non-communicable diseases. So let's just go through the signs of insulin resistance so you can evaluate yourself and see whether or not you suspect that maybe you have insulin resistance. The first one is belly fat. So I'll say to patients, if you walk towards a wall and your stomach hits the wall before your nose does, chances are you have some insulin resistance. Mid-afternoon energy slump, so you're sort of fine, you've got energy, and then after lunch you actually just want to put your head down on the desk and go to sleep. Very sleepy after meals. Low blood sugar, in other words hypoglycemia, is another sign of insulin resistance. It basically means that your body's not managing the insulin properly. An elevated HbA1c. Now the optimal levels are between 4 and 5%. So if you have had your HbA1c checked, then just go back and get those test results and have a look and see what your percentage is. If you haven't, and you next visit your doctor, if you can, get your HbA1c checked. Elevated fasting insulin, the optimal is less than 5 milligrams per deciliter. Again, if you can get it tested, obviously it gives you a more definitive diagnosis. But if not, one has to look at the other signs really or symptoms to see whether or not there's a possibility that you are insulin resistant. And mood swings, so mood swings, anxiety, depression, they all indicate neurotransmitter imbalance, and there is an association between neurotransmitter imbalance and insulin resistance. Now, the other dangers of insulin resistance is prolonged inhibition of fat burning. So if you're insulin resistant and you're trying to lose weight, it's really a struggle. Damage to blood vessel linings. So the flood of insulin, which is associated with the dysregulation of sugars, damages the blood vessel linings. Systemic inflammation. Now, systemic inflammation is also associated with increased risk of heart attack or any cardiac problems. Increased C-reactive protein, tumor necrosing factor, and insulin-like growth factor. High blood pressure. Initiation of any cancer. Now, cancer, one of the causes of cancer, one of the contributing factors of cancer is increased oxidative damage and mitochondrial cytopathy. And both mitochondrial cytopathy and this increased oxidative damage is initiated when you have insulin resistance. Alzheimer's and dementia, and fatty liver. Now, fatty liver, non-alcoholic fatty liver disease, NAFLD, is now becoming very common. So NAFLD is one of the conditions that goes hand in hand with insulin resistance. So what causes insulin resistance, and what can we do to change this. And believe me, we can. With some knowledge and dedication, we can definitely impact on our present diagnosis of insulin resistance or our risks of developing insulin resistance. Now, firstly, what is insulin and how does it work in the body? So insulin is a hormone, and it's a messenger hormone. So it's formed in the pancreas, and its job is to load up glucose and to carry it into the cell via your insulin receptors. So what happens is the body uses glucose as a fuel, and obviously this fuel allows the mitochondria to put out an energy currency called ATP, and the body uses glucose and fat, in actual fact, as this fuel. But the glucose cannot get into the cell on its own. So if, for example, you eat, now you have glucose in your blood. The glucose might be flowing in the blood, but it can't get into the cell where the mitochondria are without insulin. So insulin picks up the glucose, it takes it to the cell membrane, it almost like knocks on the cell door, it docks on that cell membrane via insulin receptors, and the glucose can then be carried into the cell through the insulin receptors. But the message that insulin tells the body is to store energy. It's a carrier for energy, and the message is store energy. So insulin is, as a messenger, it tells the body to store energy, but it's also an anabolic hormone. In other words, it's a growth hormone. And growth hormones are great as you're growing, and they're great for repair. But if you have too much insulin and you've got this constant flood of insulin and it's triggering the anabolic growth, it's also going to trigger the growth of cancer cells. Now, carbohydrates trigger insulin. So when you eat carbohydrates, your body floods out insulin because then the glucose part of the carbohydrate is able to be carried into the cell. It promotes the conversion of all this excess glucose to fatty acids. So if you have a constant flood of glucose, or too much glucose, then the body cannot deal with the quantity of glucose, and it's going to convert the glucose to fat, which of course we don't want, and insulin promotes that conversion, and insulin also assists in protein and fat metabolism, which we're not going to address in this particular lecture. So insulin is important. We cannot live without insulin. So that's why type 1 diabetics need to have insulin injections, because without insulin, the body cannot utilize the glucose. But if you have too much insulin, that also causes problems, because too much insulin then produces insulin resistance, and then that has its own impact in the body. So the causes of insulin resistance are what we eat. So if we're eating too many carbohydrates and your body's constantly flooding out insulin to manage the carbohydrates that we're eating, think of it like this. It's a little bit like if you've got a child who's constantly nagging you. Eventually you just switch off. The cell does the same. If the cell is constantly bathed in insulin, eventually there's a response that says, thank you, I have enough insulin, and it closes off the insulin receptors. So the body then, the cells become insulin resistant from being constantly bathed in insulin. So what we eat, as I said, if we're eating a lot of carbohydrates and there's a lot of insulin that's being secreted in response to the carbohydrates, you can develop insulin resistance. Obviously, this is not an overnight issue, which in a way is helpful, because if we haven't reached the point where our insulin resistance has converted to type 2 diabetes, then we've got time to start addressing a change. How often we eat. So if we are nibbling all the time, if we're grazing all the time, every single time we eat, our pancreas secretes insulin, and our cells are constantly bathed in insulin. So how often we eat is a problem. Our genetics, they feed into the particular problem. So for example, the Indian heritage, they tend to have gene inheritance that predisposes them towards developing insulin resistance and diabetes. Stress plays a role, and I'll address stress now. Inflammation increases our risks of developing insulin resistance. Excessive oxidative stress, so if we are exposed to a lot of free radicals, our risk is increased. if we don't sleep. So they've actually found that if you even have one night of very poor sleep or one night of insomnia, it affects how the body actually manages the sugars. Obesity, so when you're overweight, certain nutrient deficiencies, so for example magnesium, if you're deficient in magnesium, magnesium helps the integrity of those insulin receptors. So when you are deficient in magnesium, the insulin cannot dock effectively on the cell wall because the insulin receptor doesn't have integrity. And magnesium and chromium, these are all nutrients that help the insulin function properly in the body and dock properly on the insulin receptors. And gut disorders. Now, gut disorders, so certain gut bugs, not only are they pro-inflammatory, but certain gut bugs increase the body's absorption of sugars, for example, over, let's say, fats. So depending on what we eat, depending on the integrity of our gut bugs, this may also contribute to causing insulin resistance. So what small changes can we make that will have a big impact on our risk of developing insulin resistance? The first is to cut out carbs. Now, remember, vegetables are also carbohydrates, but the impact on the body eating vegetables is very different to the impact on the body when you're eating processed carbohydrates. So, let's say 100 grams of broccoli has a completely different impact in the body compared with 100 grams of white bread, for example. So when I talk about cutting out carbs, I mean cutting out all processed foods and those high glycemic index carbs, such as white bread, or any bread actually, biscuits, any sugars, pastas, all of those. If you cut those out, it minimizes the impact. Eat 2 to 3 meals a day and don't snack. And this again is because I've mentioned, if you eat 2 to 3 meals a day, you have a space in between where you're not eating, which allows the amount of insulin that was secreted over the meal to actually dissipate in the body. Because you don't want your body to be constantly flooded with insulin. Because again, as I mentioned, the more insulin that's bathing the cells, the greater the risk of the cells forming insulin resistance, where they're saying, thank you, no more insulin for me. Intermittent fasting. Exercise, because exercise reduces the stored sugars in the muscles. So then when you eat, because sugars can go directly into the muscle. It doesn't have to be processed by the liver. When you eat, if you need, it's almost like a storage depot for sugars in the muscles. But if you don't exercise, that stored glycogen or that stored sugar in the muscles never has a chance to burn up. So repeated meals has no place for the sugar that's coming in on the meals to actually store. Correct supplements and get proper sleep. The stress response. Now, when you are stressed, when you have chronic stress, whenever we stress, our body releases adrenaline and cortisol. And this is our fight or flight response. So it's a natural response. But what we want is that if, for example, you have a stressor that's applied to you, you can deal with the stress, but then the stress must go away. Your body must cope with it and the stress must go away so that the levels of cortisol and adrenaline go down. If you are in a chronic stress situation and you are repeatedly stressed, the levels of cortisol and adrenaline do not go down. And what happens is that when the body perceives it's in a fight or flight situation, it actually forces the muscles to release glucose into the blood. Because the body doesn't know, am I going to have to fight or am I going to run away? And then I need energy in the blood to do this. And it's effectively like getting a snack. Every single time the glucose is released into the blood, it's like your body's had a little snack without the pleasure of even putting it in your mouth. And this repeated flow of glucose in the blood and this snacking almost from the stored glucose in the muscle stimulates your insulin. And you have that insulin response again with insulin constantly bathing the cells then starting to become resistant to the insulin, too much sugar then that's developed. So residual sugar that's in the blood is then stored as fat. And of course, you get this vicious cycle of developing insulin resistance. So a little parting analogy. If you were to imagine our body is like a city. For the city to work well, you need a power plant. So our mitochondria, which are little organelles in our cells, would be equivalent to the power plant that the city would need. We need solid walls of integrity that are not crumbling, and our cell membranes provide these solid walls. We need a Department of Defense, so we need our immune system is equivalent to the Department of Defense. We need effective sewage system, well, that sort of goes without saying there. We need communication, so good Wi-Fi and internet. So our hormones, in actual fact, is the way that our body communicates. We need roads, and we need roads that have integrity and are in good repair. So our blood vessels would be equivalent to the roads. We need efficient city employees. So, for example, our enzymes are equivalent to efficient city employees. And of course, we need a parliament, and our brain would be the parliament. So if you think about our body as a city, all of these factors are important to be working well for the integrity of that city, or in our case, our body, to work efficiently and to resist attack. And what insulin resistance does, it's a little bit like termites. It just chews away at the integrity of that city until eventually it just falls in crumbled ruins. And I want to mention, if you had this beautiful car, would you put in anything but top grade fuel? And if you want your body to be like this beautiful car, you have to put top grade fuel into your body. You can't put rubbish into your body. Otherwise, eventually, it's just not going to run cleanly. So with our car, we do a yearly service. We have no problem paying for a yearly service, but very often with our body, we are unwilling, or perhaps we just don't know what we should be doing, but we need to do a yearly service. So while you are turning your body around, and before NHI comes in, and we do have time, do a yearly service, get these lab tests, and make sure that the results are as reflected here. So your HbA1c between 4.5% and 5, fasting insulin should be less than 5, fasting glucose less than 5, homocysteine between 6 and 7, ferritin, that measures your stored iron, between 90 and 110. Iron is very inflammatory. So if you are a man or you are postmenopausal, it's really important to check your iron and make sure your iron levels aren't creeping up, because it's very easy to get rid of them. You just go and donate blood. Your high-sensitive C-reactive protein should be between 0.5 and 1. And high-sensitive C-reactive protein, when it's as high, is correlated with increased risk of cardiac events. Your vitamin D should be between 50 and 60. And the darker your skin, the harder it is for your body to absorb vitamin D. Thyroid, your TSH should be less than 1.5. If your TSH is greater than 1.5, then you need to check your T4 and your T3. If you need any extra help with regard to this, please feel free to contact us. You can email us at health@live100.co.za, or go and have a look at the website, www.integratedhealthassociation.com. So thank you for your time, and I hope this has helped you, and I hope this helps you to avoid getting sucked into the vortex of NHI.